Thank you, George. Now, my disclosure is John was my mentor, and we are colleagues, and we do cases the same way. And we still perform a lot of atherectomy. We still perform a lot of lithotripsy. And the key is that we saw cases, right? If we saw Dr. Keeney and Dr. Sharma's cases, feels like everybody should get a rotablade or CSI, right? The key is calcium, John showed, is very, very undertreated. And we've become very smart in how to treat calcium. And so I'm going to show why IVL, where IVL fits in, and why I think that the operators who do very high volume, which hardly exists nowadays, we have operators who do low volume and stuff. So we need to have technology to manage these patients. And that's why I think IVL is going to be good enough. So these are my disclosures. And so these are some of the cases that I may, if I get time, I'll show, but how do we treat these lesions? So you can see uncrossable lesions, obviously, high-grade lesions, single vessel supplying the whole myocardium, and osteal lesions. So, when we look at these, we want to run away from these cases, but we can't, and we need to understand really how we better manage these patients. So lithotripsy, everybody's familiar with, soft on soft, hard on hard. It really works, just like John showed, it works very, very well, creates a sonic pressure wave, which is pretty close to about 50 atmospheres. Laser actually works on calcium, but laser in an uncontrolled environment, if it interacts with dye, it gives you 100 atmospheres. The problem is it breaks calcium, but it also breaks the whole vessel, so you have to be very careful. But this is similar mechanism with this sonic wave. It creates probably close to 50 atmospheres, and you can see that here. So I'm not going to go over. You guys are very familiar with it. So if you look at it, there are challenges of atherectomy. Atherectomy, the reason why John showed that atherectomy is still used in single digits is because it has complications. People are afraid. We are not afraid because we've been doing it for years. But most people who do cases in the United States don't like to do atherectomy, and if they do atherectomy, they get the reps in there, and they have complications. You got to do more of these. So that's why we need some form of technology to treat this patient, and that's where I think IVL really comes in picture. We can treat bifurcations, you can protect with side branch, and you can really modify calcium, provided you can cross it. So there's a lot of data. I'm not going to go over data on IVL, but I'm going to show you something which is more attractive really across the board is compared to the Orbit data, it's very, very safe procedure and it's very effective procedure. And there's really no learning curve. As I said, it's just like a balloon. If you can get the balloon, and if you can prepare the balloon well, then you get good fractures and you have good luminal gain. So it's very, very important. The key attractive part here is, like I said earlier, the complication rate across the board with lithotripsy is very, very low. You can see that. So now we become smart. So now we have technology, and we do imaging, right? And everybody says you got to do imaging to understand how we treat calcium. Concentric is okay. Concentric in general, with wire bias, you have orbital, you have rotational, you have, you can break some calcium fractures, yield it, and do. Eccentric and nodular, we didn't understand too much. And now we understand a lot about these because these are very common, especially in tortuous arteries, especially in right coronary arteries with nodular calcifications and the different types of nodules. We never even knew nodule mechanisms, but now we know eruptive nodule is like an ACS. It acts differently. Outcomes are very different. Healed nodules are very different. And then eccentric calcium, how do we treat them? So now we become smarter in treating these patients. And you can see here, concentric calcium, we know both of the things work. Atherectomy and orbital works very, very nicely. Thick calcium, thick superficial calcium, fractures and good stent expansion. But nodular, you can see balloon therapies, obviously the way the balloon inflates, you get dog boning and you don't really get maximum pressure where you're supposed to get maximum pressure. Then you really, what you create fractures, but you create fractures with the path of least resistance and you don't do anything here. And atherectomy is dependent on wire bias, really. There is some theoretical things with orbital that people say that you get deep calcium and sometimes you change the compliance and you can have some fractures of nodules, but in general, atherectomy is limited in those scenarios. And then when you do that, even then, this is what you see on imaging after you are done. So this is not ideal. Eccentricity index is very poor. The luminal gain is very poor. And so if you can see IVL across the board, you can see, in the nodule here, you actually create these kind of fractures, and then you have a very good chance of actually creating the eccentricity index to be greater than 0.8, which is actually in these complex scenarios is much better. So meaning this diameter versus this diameter should be greater than 0.8, and which is very important in nodules. So you can see here, IVL across the board, nodules and no nodules, these outcomes are very, very similar across the board. And this is the only technology that really shows you, atherectomy is actually limited in nodules, really. So you can see eccentric calcium, similar sort of scenario. Atherectomy is dependent on your wire bias, and whereas IVL is not, and we talked about that. So in here also you can see eccentric calcium, it actually has very, very similar minimal stent area, whether you have eccentric calcium or concentric calcium. And then so we talked about nodules. You can see eruptive nodules and nodular calcification. You can see CSI and rotational atherectomy, depending on where your wire is. In the old days, we used to actually change the wire bias by pulling the wire and changing your wire bias to do that. Now we have technology, actually, we don't need to do that, and you don't gutter the wall in nodules. So it's very, very important. And you can see right coronary arteries usually have larger amount of, because of the where the endothelial shear stress is, and the nodules are really important. But you can see the important thing is that with IVL, you can see across the board, stent expansion, minimal stent area for nodules and non-nodular is very, very similar in IVL. So pretty promising technology in all types of eruptive, healed nodules and concentric nodules. So in eccentric calcium, IVL. In nodular calcium, IVL. And this is something that we don't know. Female aorta is very different. Female coronary arteries are very different. Females have higher bleeding risk, low body weight, and high body weight. Actually, in calcium, there is a very high complication rate with atherectomy in females. And you can see across the board, males versus females. This most people are not aware of, but this is a very, very, so I think when you do these complex patients with calcium, you got to treat a patient and you look at a patient and you say risk scores and all these things, but you have to look at what you're treating. And it's very, very important to understand that these are different biology that's in play. And you can see here, target lesion failure between men and women across the board with IVL is pretty much the same. Okay, so you say here, if you look at the SKY, position paper, you can see that IVL may emerge as the first line therapy for calcified lesions, especially in women, because of this analysis. And then there is a study going on, Empower CAD, which actually addresses that question really in females. So it's very, very important to know that to minimize complications, IVL may be the standard in female patients. So John showed this. I'm not going to show this, but I added this here as a female nodules and deep calcium. And some people, especially with chronic kidney disease, people have both superficial and deep. So if you break the superficial calcium for you to increase the compliance and the luminal gain, I think affecting the deep calcium is also very, very important. So I'm going to just run over these things here. So this is my sort of summary that I made up. Calcified lesion subset scenarios for IVL. Left mains, yes, big vessels, easy to cross. You can do both limbs quickly with wires. Bifurcations, obviously, very attractive. Osteal lesions, I think we've switched now to from atherectomy to IVL. The reason is I'll show you cases is because unless you're coaxial, CSI can actually dissect the cusp. People have had severe AI from CSI if it's not engaged in coaxial. Rotational atherectomy works, you start in the guide, but you have to be coaxial and you have to be careful because if you take a smaller burr and you go, you can trap the burr. But this is very, very attractive. ACS patients, a lot of ACS patients you see with calcium and with thrombus laden IVL is good. Large lumen, tortuous anatomy, really not really dependent on wire bias. Obviously balloon and atherectomy failure. Not indicated right now, but under expanded ISR, which is if it's a nodule behind the stent, it actually works well. And then I put a question mark on female sex. So majority people, IVL, except John told us that long lesions and failure to cross are the only scenarios I feel for general interventional cardiologists in this country. That these are the scenarios to learn IVL, understand. Sometimes you might have to pre-dilate or do it, but IVL fits in most of these scenarios to really better manage the patients with calcium. So summary is ease of use, excellent profile, excellent data, promising, and we talked about. So I'm going to show you one quick case here, and I'll show you why it is important for us to understand what type of calcium and how to treat it. 84-year-old patient, presented outside hospital with AVR ST elevation, which means left main disease pretty much. Troponin is high. They put a balloon pump and you can see the EKG is bad, and this is what the artery looks like. Pretty bad, right? Calcium, these are not stents, this is calcium. We actually crossed it with a workhorse wire, but the microcatheter would not cross. So just what John told us, we put a Viper wire down and we pushed. When you do these things, you push quickly, go forward, cut backwards so they don't dissect the cusp. And we did that and we created the channel. You can see the channel is there, but when you put a non-compliant balloon, you see dog boning here. The reason was there was superficial calcium in here. There was big nodule right at the ostium from the aorta, and it would not yield. And then, so we had to do shockwave, and that's what shockwave did. And then, we imaged. Obviously, we couldn't take imaging before we marked the ostium. And then we gutted the lesion. You'll see that we gutted with the CSI on the other side. This is all guttering of the artery, and the nodule was actually on the other side, and that nodule actually would not yield at the ostium, so we had to do shockwave, and then we stented it and protected the circ, and then that's the magic right there. So anyway, I'm going to stop here. Thank you very much for having me.
Well, that was a terrific presentation, and as we get